What is up, everyone? Welcome back to the channel. It is, I think, my third week of surgery rotation. Everything is already starting to blend together, but I am on my elective weeks. So my surgery rotation is 8 weeks long. There's sort of three components to it. You get 4 weeks of general inpatient where you're kind of rotated between a bunch of different teams. You get 2 weeks of an elective, which is actually, it's pretty similar to the inpatient teams. You're just like guaranteed to be on a certain team for 2 weeks. So the three different teams for the inpatient weeks are blue, red, and gold. Red is thoracic and vascular. Blue is sort of just like general surgery, so a lot of abdominal stuff. And then gold is kind of crazy. It's like breast, endocrinology, oncology, a bunch of different stuff. And then for my elective, I'm on vascular. So that means that I just have an extra 2 weeks on the red team. I am supposed to basically be working with one doctor. He's definitely not going to be there operating every day. So whenever he has a case, I'll try to get in it. If not, I'll work with some of the other vascular surgeons and then maybe get a little bit of thoracic in here and there. And then finally, our last 2 weeks are trauma, which I already finished. That was my first 2 weeks. Go check out my last few videos if you want to see what trauma was like. So like I said, I'm on my elective, which is vascular surgery, for the next 2 weeks. Today's Monday, and Mondays we usually have core curriculum, which means we don't really go into the hospital and work. We have different sorts of lectures. They're usually virtual, but today was a little bit different. We actually had a pretty free morning, but then the afternoon was when all of the events happened. So we actually had a bunch of trauma sessions, which looking back would have been a lot more helpful before I did trauma, but at least, I went into it knowing a lot already. So we had a lecture from one of the trauma surgeons that I was able to work with a little bit, so that was cool to see him again. So it was like an hour lecture, and then we did some simulations. So we did a simulation of a trauma. It was, pretty low stakes. The doctor was in there with us to sort of walk us through everything, and we were in groups of like 8, so we had sort of a huge team, but we walked through the different steps of, someone comes in after a motor vehicle accident. Basically, what do you do? All the different steps of, securing the airway, making sure they're breathing, making sure they're circulating, surveying for different sorts of injuries, and the different kind of like imaging and labs you want to get right off the bat to sort of figure out everything that is going on. So that was pretty cool. We've done a few of these simulation things back, up in campus during OSCEs or just other clinical skills days where, you're working with a high-tech mannequin that can have different heart or lung sounds, and, there's an actor that can talk to you and stuff. So obviously it's not like the real deal, but it's still something that is really beneficial from a learning point of view. These next 2 weeks are going to be a lot different from what I was doing on trauma. Obviously for trauma, you don't have a lot of scheduled surgeries because, you have to wait for them to come to you, but a lot more of the trauma day is spent rounding, actually. A lot of these patients are pretty complex, so every day there was, some virtual rounds, which involved, I think, most of the attendings and, the residents and PAs and all that. And then after that, we would actually do walking rounds on some of the patients that we needed to see. So, and that would go from pretty much like 6 a.m. was when sign out was, and then we might get done with walking rounds around like 10:30 or 11. The other services, the red, blue, gold teams are very different, so you get it there a little bit earlier. I'll probably get there at like 5 tomorrow. Look on the list to see a patient to round on or pre-round on. Go see them by myself, do a little chart review, and then I'll meet up with the residents around like 5:45 or 6, and then we'll go walking around the hospital seeing patients that need to be seen. While I'm walking there, I'll maybe give a presentation on the patient that I saw, and then we'll do rounds just with the residents, so kind of mapping out the whole day, figuring out which patients are going to the OR, which patients need, different bedside procedures, who can get discharged, all that kind of stuff. And then 7:30 is when cases start. So, they try to have everything wrapped up before then, all their notes written, everything like that. So the morning can be really busy. And then depending on what surgeries I have for the day, sometimes my surgeries won't start till 1 o'clock. So then I'll have a little bit of time to go and study or see if I can help out with anything on the floor. Or sometimes my surgery will start at 7:30, so I will have needed to prep everything before that, know the patient, know what procedure they're getting and why, and all that stuff. So it is going to be very different, but I'm pretty excited. Alright, what is up? It is Wednesday, and I just want to do a quick check-in and talk about how the week has gone so far. So like I said, I've been getting to the hospital around like 5 o'clock, picking 1 or 2 patients to go and pre-round on, so I do a chart review and then go see them. It's usually pretty fast. I always talk to the nurses because they usually have a really good idea of what went on overnight, and the good thing about getting there so early is a lot of the nurses, they're the overnight nurse, so they knew everything that happened overnight. Back when I was on IM, when you would go see the nurse, the shift had like just changed. So they're relying on the, sign out from the other nurse. So I'll go to talk to them. Then I'll go meet up with the residents, we'll round. Then if there's a 7:30 surgery, then I'll head up to pre-op, introduce myself to the patient, ask if it's okay if I come into the case and help the surgeon out. Then I'll go to whatever OR the surgery is scheduled, introduce myself to all the staff, pull my gloves or gown if they need me to, and then I'll just kind of hang out around the patient. And once they are rolled over to the OR, I'll let the resident know, and we'll start getting everything set up. In terms of the surgeries that I've seen so far, I saw one BKA debridement. So BKA is a below the knee amputation. So people have this for a variety of reasons. I think one of the most common things is, diabetic complications where they have really bad neuropathy and then they get ulcers and, they're not healing. So you have to get a below the knee amputation. Also can happen if you have some sort of trauma to the area, but unfortunately sometimes even after you get a BKA, some area isn't healing properly, so you have to go out and sort of clean out the injury and, pack it with certain things that help it heal. So I've seen a few of those. And then one of the more interesting things I've seen this week so far is a temporal artery biopsy. So there's this condition called giant cell or temporal arteritis, which is inflammation of your temporal artery. And the way to confirm it is to do a biopsy of the artery itself and look at it under the microscope. So it's a simple but pretty cool procedure where, they'll feel for the pulse of the temporal artery, mark right where it is, cut into the skin, go down very carefully as to not, accidentally cut the artery, find it, tie off either end, and then they'll take a section of it and send it to the lab so a pathologist can analyze it. And the reason they do it is to confirm this condition, giant cell arteritis, because patients have to be on steroids for a really long time, and if you don't actually have that disease, then you don't want to be on steroids for over a year if you don't have to. So yeah, those are the 2 big procedures I've seen so far. I think I have some more involved and intense procedures coming up later in the week, so I'm excited to talk about those. Alright, it is Sunday and I've had a very exciting past few days. So the end of the week went pretty similar to the beginning, where got there around 5, pre-rounded, rounded, then went to cases all day. I was averaging probably a 12-hour day. I would get there around 5, leave around 5 or 5:30. Definitely some long days, but honestly, when I'm in a bunch of cases in the OR, it goes by pretty fast. In terms of the actual cases I got to see some really cool, unique cases, things that are a lot more involved than the stuff from earlier in the week. So something I saw on Thursday, I saw an abdominal aortic aneurysm repair. The specific type of repair is called a FEVAR, which I think stands for fenestrated endovascular aorta repair. So basically what it is, sometimes your aorta, which is the big blood vessel that goes from your heart all the way down to your pelvis. Sometimes parts of it can get too distended or get sort of an aneurysm, just like a bulging in one of the areas. Sometimes these are discovered incidentally on imaging, and then you're like, oh, you have this, we're going to follow it. And once it either starts causing you symptoms or, God forbid, ruptures or gets to a certain size, then you have to think about doing some sort of intervention to repair it. Usually once it gets to like 5.5 centimeters, you have to do some sort of repair. So I think that's what happened to this patient. They have had it for a very long time, but on their most recent scan, it was greater than 5.5 centimeters. So the surgeon was like, all right, well, you have to do something about this because now it is so big that it has a higher chance of rupture, and that can be really, really bad. So they chose to do an endovascular technique where basically they made incisions in both of the patient's legs and then were able to thread different wires and catheters up into the aorta. And they were able to put a stent in right where the aneurysm is in order to sort of streamline the flow and sort of support that area so it wouldn't keep increasing in size. And this was actually complicated further by where in the aorta the aneurysm was. It was actually involving the renal arteries. So, if you put a stent to that area, you would maybe block the blood flow of those arteries, which would be really bad. So what they did was they took the CAT scan and they sent it to a company that made a special graft or stent like specific to that patient's anatomy. They had fenestrations or holes in the stent so it wouldn't block the blood flow once they placed the stent in the aorta. They had these holes in the specific areas where the patient's renal arteries were branching off so it didn't block the blood flow. So I think that is pretty crazy. So amazing that they can custom make something like this for every patient just based on a CAT scan. So unfortunately, I wasn't really able to do much in that case. I didn't even scrub in, but I was able to see everything on these giant TVs that they had. And yeah, all in all, very interesting case. And then another really cool thing I got to see Friday was a femoral endarterectomy, I think is how you pronounce it. And this is for someone who has sort of stenosis or a plaque in their femoral artery that is causing them symptoms down their leg. So similar to the heart, where you can have blockages and plaques in your coronary arteries, you can get that in any artery in your body. The carotid and femoral arteries are other big places where we're concerned about this happening, so they have special techniques to treat that. One of which being an endarterectomy, which is an open procedure, which means it's not like minimally invasive. You cut directly into the skin and open it up. So basically what it is we, found the patient's femoral artery with ultrasound, drew a line right over it, and then made a cut down all the way to it. We clamped the blood flow on either side of the artery and then cut into it. Once we cut into the artery, we could see the plaque itself. It was pretty big. It was, looked like a calcium deposit. It was like sort of a whitish yellow color, and then they literally just pulled it out with some forceps. So it was very crazy to see, the inside of an artery. They just pull out this plaque, and then basically that's it. You just have to close it. At first I thought that you would just suture, the sort of walls of the artery back together like they were, but the doctor was explaining if you did that, then you would actually sort of decrease the circumference of the artery. So that's, a bad thing. We were just trying to treat this patient for a narrowed artery, so if we did that, we would be kind of back to square one. So what they do is they have a patch that is, it just kind of almost looks like a strip of paper, and then they'll suture, one end of the paper to one end of the artery, and then, vice versa, and it's basically like replacing some of the wall of the artery with this artificial graft, and that's just to make sure you're not making the artery too tight when you close everything up. So once again, really cool procedure, just like amazing that we can do surgery directly on blood vessels. I don't know, I've really enjoyed vascular. I've seen a lot of different kinds of procedures, some really technically demanding things, but I really like the mix of being able to do open procedures and minimally invasive stuff. Gives a lot of variety so you're not doing the same thing every single day. And then after we were done work Friday, we went out for some drinks, me, Mackenzie, and a few of my friends that I'm rotating with on surgery. So that was nice to unwind after a very long week of working 12-hour days. And then the weekend has just kind of been catching up on studying. Depending on how many cases you take a day, you can either have a lot of downtime to study or none at all. Some of these cases that I've been in have been 3-4 hours, so if you do 2 of those, then that's your whole day. So since I was in some of the longer cases, I didn't have a lot of time to study during the week, so I had to catch up this weekend. All in all, I've been really enjoying vascular. Kind of sucks that I only have 1 more week of vascular, because then I move on to team blue and gold, which I'm sure will be really good too. So far I've been really liking vascular. Alright, well that is going to do it for today's video. If you enjoyed, please be sure to leave a like below and subscribe if you want to see videos like this in the future. Thanks, and we'll see you in the next one.